Some of you have asked me about bronchoscopy in preterms. Let me show you this case. This is a case of a preterm 27 plus 6 weeks, 930 grams, with partial lung maturation, who essentially was born on on acceptable conditions, into CPAP, FiO2 of 30%, went on the BiPAP, had to have some Curosurf because FiO2 increased requirements, but he responded well, and at 16 hours of life, he went back to CPAP. However, on day 2 to 3, he developed a massive pulmonary hemorrhage, and that led to a very severe cardiorespiratory arrest. He had to be intubated, prolonged CPR for around 35 to 40 minutes, and went into high-frequency ventilation. This is the X-ray showing bilateral infiltrates. And essentially, on the second week of life, they were able, essentially, between these days to the second week of life, to win the FiO2 requirement. But in sample, he deteriorated with increased FiO2 requirements, secretions, and CRP. They started antibiotics, but on the X-ray, guess what? There was again a lung collapse. No bronchogram on the right upper. So essentially, we did a quick bronchoscopy through a size 3 ET2 with a 2.2 millimeter scope. And again, we identified an area of obstruction of the right upper lobe. The ET2 was also impregnated with thick yellowy secretion. This is another close image of the cast. So in this situation, we were a little bit more compromised because of the space. We also identified this area of mucopurulent material on the right lower lobe, on the right lower bronchus. And essentially, we wanted to know whether this was a thick clot or a thick structure or not. So we were able just to go through it. And as soon as we went through it, it went a little bit down. So that was mobile. So we thought that we could treat it a little bit, but this 5.2, the 2.2 hasn't got a working channel. So we installed some saline, and we used a combi-cath, bronchial catheter, to suction the mucopurulent material. Before we did that, because we couldn't see, we just turned the head to one side and turned it to the right, and just proved that we could go straight into the right main bronch. So that's exactly how we place our combi-cath. This is essentially the result of the suction. It's this one here has disappeared, but still we have the fixed right upper lobe cast there. So we added some DNAs, diluted DNAs, and we reconnected the patient and left him resting during 40 minutes on right lateral decubitus. We did some physiotherapy, and again, the cast was still there, looking exactly the same. So at the end, this led to a very difficult situation. We evaluate the risk-benefit. We concluded that we really needed to unblock this right upper lobe, because essentially otherwise he wouldn't improve from his ventilator situation, and we wouldn't be able to treat his VIP pneumonia. So the patient was reintubated using the flexible scope with 3.5.
Sorry, Dr. Peridranzo, you should be ending here.
I'm almost finishing. Thank you
very much.
Thank you. So because we essentially needed the bigger tube to pass our 2.8 non-disposable, because this one has a working channel of 1.2. We upgraded the ET tube connector as well with a size 4 ET tube connector, and we tried to treat the clot with our bronchoscope. And essentially, we installed some DNAs, we tried to suction, and after a few attempts, and this is us trying to suction the DNAs. In some point, we were able to unblock partially the right upper lobe with a lot of pus coming from all this area. And essentially, this is the progression of the patient. The patient did well, had some wind on the ventilator. This is the unblocked lung, and this is the X-ray, which is really improved. And we got the PCR result on the BAL from Heterobacter cloacae only 2 hours after we did the procedure. We upgraded the antibiotics to meropenem. Those results were confirmed microbiology because of the cultures, and the patient essentially did progressively well, and essentially was extubated around, I think, 5 days later or so. So yes, well, I think I'm going to stop there, but there is, there was a lot of, fibrotic intubation stuff, but I could just explain you, in another situation. And also we have used the bronchoscopy as well for bronchial blockage on few patients, along with anesthesia, which work really well on empyema patients going for VATS. So thank you very much. And my conclusions will be, it's up to you guys. You need to make your own thoughts and conclude whether you want to learn this technique. But if you need to discuss it with your colleagues, decide whether this could be helpful for your patient. But if you decide to do it, you need to get a good learning and go with adults. They really have a long list, and you could really specialize with them and work along your pediatric respiratory teams, which are great, and your intensivist colleagues. And if you don't find the course, you can always go to my pediatric bronchoscopy online course, which you can go through it because using this QR that will be released soon, within probably 25 days. The Spanish version is already online. Well, thank you very much. And, it's been a pleasure to be here. And this is the people